Good evening, dear doctors. I'm Dr. Ketan Kulkarni from the medical services team at Emcure Pharmaceuticals Limited. On behalf of Emcure-Dix, which is a division of Emcure Pharmaceuticals Limited, I welcome you all for this webinar. And the topic for today is cyclosporine usage in dermatology. So the moderator for today's event is Dr. Mukesh Girdhar sir. Dr. Mukesh Girdhar sir is a renowned figure in dermatology in India. So I will just give his introduction. Okay, so sir is practicing in his own clinic in Delhi and at Max Super Specialty Hospital at Patparganj in New Delhi. Sir has been the National Vice President of IIDWEL in 2018. He's a President IIDWEL Delhi State Branch in 2015. He has received many awards. He is the recipient of IIDWEL Derma Practice Award in 2020 and the Best Practicing Dermatology in North India. He is also the recipient of Professor Sardari Lal Memorial Award in 2014 for outstanding services in the field of dermatology. And sir is also the recipient of IIDWEL Presidential Award in 2021. He was the recipient of Professor K.C. Kandari Best Award and for the best resident at AIIMS New Delhi in 1991. He was honored with the Times Healthcare Award in the category Legend in Dermatology in 2018. He has been the recipient of the Economic Times Inspiring Dermatologist Award in 2021. He has been the International Fellow at American Academy of Dermatology and European Academy of Dermatology and Venereology. He is the member of the International Society of Dermatology and International Society of Pediatric Dermatology. And sir is also on the editorial board of many journals. He has delivered more than 200 talks and guest lectures nationally as well as globally on various topics. He has also published papers and contributed to various national and international journals. So I would like to thank Dr. Girdhar sir for his consent for being a moderator today. And I now call upon Dr. Mukesh Girdhar sir to introduce Dr. Vinay Singh, sir.
Thank you so much for Emcure for holding this meeting on cyclosporine, which is such an important molecule in dermatology. People need to, learn more about it and to, use it much more. And who better than Dr. Vinay Singh to tell about it? Dr. Vinay Singh is known all across the country as a leading dermatologist. He's the director of the Vibrance Wellness Vista. Of course, he's a member of the IADVL, AXI, IAS, STD. His interests are in immunology, psoriasis, dermatosurgery. He has publications in the Journal of Dermatologic Research and Practice, IDOJ. He was the president of IADVL Delhi State Branch in 2021 and was the vice president in 2023-24 at the national level. He was the invited speaker in the Dermacons, Cuticons, then WCDs, SARC-AD, etc. And he holds certain awards also, University Gold Medal, Dr. Sardari Lal Memorial Award at IADVL also. So before I hand over to Dr. Vinay Singh, I just want to mention that cyclosporine is a molecule which has been used in various disorders, including psoriasis, atopic dermatitis, chronic spontaneous urticaria, and so many other indications. We will want to learn more about it in details from Dr. Vinay. Dr. Vinay, please.
Thank you, sir. Thanks, Emcure, and thank you, Mukesh, sir, for giving me this opportunity. Mukesh, sir, for your nice words. And of course, cyclosporine, we can say that cyclosporine can be termed as master of various diseases, which are off-label also. Cyclosporine has been used in dermatology since very long time in various diseases, but we cannot cover all the diseases of where we are using cyclosporine. I'll just pick up few of them and which are more commonly seen and where we have a huge experience. I started using cyclosporin way back in 1996, end of 97, and there has been no turning back. It has been a wonderful molecule in my treatment practice, armamentarium. So I think my slides are visible now.
Yes, sir. Yes, sir. Can start.
Okay. So the topic is cyclosporin dermatology. I wanted to keep this topic cyclosporin master of all. Just an overview about cyclosporin and then usage in plaque type of psoriasis, atopic dermatitis, alopecias, then certain guidelines, recommendations, certain myths, why it should be used and what doses it should be used. Mythbusters should be we will have during question and answer. And there are various new indications where cyclosporin, a wonderful molecule, can be used. The only limitation is that it has got some side effect profile and it cannot be used for a very, very long time. That is the only thing. Now, if we talk about psoriasis, it's a worldwide problem. We dermatologists often see almost daily, we see 1 or 2 psoriasis patients in private OPD, and in government setups, more than 3 to 5% of the patients, even more in certain setups, even around 10% has been reported to have patients to be reporting as psoriasis, which is a debilitating disease, chronic papillosquamous disease, which stays there for almost whole of the life and affects the whole family. Thus, the quality of life of the patient as well as the whole family, the caregivers, is very much affected. And these patients, because it is seen, we can see from our naked eyes. We don't have to go for any invasive or non-invasive investigations to find out the disease. So patients, they feel that they have a very big problem because the whole of the skin is involved and they are not able to mix with other people. Now, just touching upon cyclosporin, the talk of today's topic, it is a hydrophobic cyclic polypeptide which contains 11 amino acids with a molecular weight of 1203 daltons. It's a heavy molecule. This was first isolated way back in 1970 from a soil fungus, and its improvement was seen in patients of psoriasis. When psoriatic arthritis patients were being treated, then it was seen that with cyclosporin, along with psoriatic arthritis improvement, pain improvement, psoriasis, cutaneous disease also improved a lot. And then since then it was termed to be used in various disorders, and gradually it was picked up in dermatology also, in various immune-mediated diseases. Now, why should it be used, cyclosporin? What is the rationale for using this particular molecule in various immune-mediated dermatosis? It affects it targets the major effector pathways which are common to both the immune-mediated and inflammatory components of the various disorders which we encounter daily. In this cartoon, we can see that there is a signal which attaches to the T cell receptor. These two dimers of the receptor, they come together, join together, and then the signal further by calcium channels through the calcium, and then the whole cascade. It's a complex thing which is very beautifully shown here in a very simple way, that it leads to dephosphorylation of the NF-ATC, which then goes inside the nucleus and produces interleukin 2 gene. So once we are using cyclosporin, it blocks the activation of T helper cells and blocks the activation or dephosphorylation of NF-ATC, and thus leads to reduction in production of interleukin 2 genes, interleukin 2 through the genes. Thus has a very huge anti-inflammatory activity, inhibits the histamine release from mast cells, and also downregulates various other cellular adhesion molecules and cytokines which are byproduct of a particular inflammatory cascade. Now, it has been studied in rheumatoid arthritis, in psoriatic arthritis, and also in plaque type of psoriasis. So I'll just touch upon few clinical studies. This one study timing of quality of life improvement in psoriatic patients treated with different systemic therapies, where it was seen that objective was to determine how patients responded to different systemic therapeutic regimens, quantifying the mean percentage of improvement of PASI and SODISC scores. SODISC is a tool, it's a physical tool in the form of a circle where various parameters are written and it is given to the patient. The patient then tick marks from day 0 to day 10 or subsequent visits up to day 30. This study was conducted, and this is published in Dermatology Therapeutics in 2019 in July. And the design was retrospective analysis on the clinical records of only 56 patients, where the patients were on acitretin, adalimumab, etanercept, ustekinumab, and cyclosporine. In cyclosporine, the highest number was in cyclosporine, 21 patients. So the result was it compared the PASI, which we are very much comfortable, although we seldom use PASI in daily clinical practice, but it was seen that of these all 21 patients, PASI score after 30 days, it was significantly improved. And SODISC, which is patient, we can say that it is patient outcome, what patient feels about the disease. SODISC is also improved very significantly. Vis-a-vis acitretin, it was shown adalimumab was also equivalent but not same. Etanercept was not as good as cyclosporine or adalimumab, and ustekinumab was also into the line, but it was not as good as cyclosporine in this particular study. The most important thing to understand is that cyclosporine, being an oral molecule, is the fastest among all of these acitretin, adalimumab, etanercept, and ustekinumab. It is one of the fastest molecules to give patient clearance from the redness, from the scaling, from itching, everything on the cutaneous surface. So here's a percentage of the patients, and it is again showing that cyclosporine gave very good results in PASI and SODISC. I have not used SODISC, but it is used in certain studies in certain countries. It's a good tool. So they said that after 30 days of the treatment, cyclosporine was found to improve both PASI as well as SODISC faster than any of these molecules. And the improvement was close to 80% in PASI, and SODISC was, which is patient-generated outcome, which was close to 95%. It was, as I said, that cyclosporine is, when we all know that cyclosporine is known to be very rapidly active for treatment of psoriasis and other cutaneous inflammatory disorders. Now, we don't use diethranol now, we don't use atritinate, but we use methotrexate. So we know that to reduce down PASI, cyclosporine will fare anyway better than methotrexate in any dose. So cyclosporine shows quicker and long-term remission. Result is very good with cyclosporine. With methotrexate, reduction is definitely there. Methotrexate being the most economical medicine and most widely used medicine in psoriasis, has got a close to 60% reduction in PASI. Now, various groups have given guidelines to use, and one of these is mentioned here, that they recommend initiating a biologic if conventional systemic agent was inadequate in giving response or it was contraindicated. But if we see nowadays biologics are taking a huge leap in the treatment of psoriasis and psoriatic arthritis, but many of our patients, they are not very comfortable taking injections, or they are not very comfortable in spending so much of amount. Cyclosporine comes handy, which is better than methotrexate, better than acitretin, and better than so many other molecules which we are using in different patients. I'm not saying that we can use any of the medication in all of the patients. So it can be used for a short duration in case we want to use biologics and the patient does not want to take injections. Again, Belgian Society, they have kept first line as biologics, anti-TNF-alpha inhibitors and anti-IL-17, which we are using. Anti-IL-23 also they use, we don't use that. And second line treatment, they said that we use cyclosporine if the response to conventional treatment is inadequate, is contraindicated or not tolerated in targeted therapies, then we can use cyclosporine. It is other way around. We can use either of them first, or we can uh, control the disease burden by using a biologic, and then just to save the money from the patient, we can give cyclosporine for a very short duration so that the remission is uh, seen for a very long time. And if we don't want to use cyclosporine, we can continue the treatment with methotrexate after we have weaned off cyclosporine, or while weaning of cyclosporine can also be, methotrexate can also be given. I am using cyclosporine with biologics as well as methotrexates both. Now, in recently, cyclosporine was found in guidelines of management of psoriasis by a Singapore group, Society of Singapore, Dermatology Society. They said cyclosporine is fast-acting and very highly effective drug for psoriasis. Level of evidence was 1 plus and A, as well as other molecules. We all know this, and this again another one, strength of recommendation for cyclosporine therapy in various other types of psoriasis in patients with severe recalcitrant psoriasis, with erythrodermic generalized pustular and palm plantar psoriasis, and it has to be recommended as a strength of recommendation C in patients who had flare up while on pre-existing systemic therapy. So we can use cyclosporine, but we must always be very much sure about the cumulative doses of cyclosporine, because it is potentially nephrotoxic if it is not used properly, not used judiciously. Now, British group also has published some dermatological guidelines, and now they say that severe psoriasis, the level of recommendation is A, and strength of recommendation is A, and level of evidence is 1 plus. There is substantial evidence of cyclosporine in various psoriasis vulgaris, be it severe, be it plaque type, be it localized, be it special areas like scalp, be it in psoriasis inversa, various psoriasis we can use. Now, the standard regimen is to to start psoriasis after proper investigation and proper counseling to the patient about, depending upon the age of the patient and the gender of the patient, proper counseling has to be given. We can start at 2.5 to 5 milligrams per kilogram per day, given orally, either in single dose or in divided doses as per the patient's comfort, because some of the patients, they do they say that they have some gastric irritation while taking cyclosporine in larger doses once in a day. And we can use higher initial dose. I use higher initial dose in toxic epidermal necrolysis or psoriatic erythroderma or GPP. I use cyclosporine in high dose, 5 milligrams, and it gives very quick and good results. And after, when the disease burden has come down, then we can start reducing down the dose of cyclosporine. We can use cyclosporine in a good dose till 1 month. If the patient is comfortable, we can reduce it before that. And if there is no response after 6 weeks on the highest possible dose which we are using, that is 5 milligrams, we have to withdraw. We have to think about other molecules or even biologics, that cyclosporine somehow is not working, or we may have to revisit our diagnosis of psoriasis, or if psoriasis is associated with some other disease, chronic condition, then we have to check our diagnosis. We can use intermittent short courses, maybe weekend therapy after the patient has achieved good clinical remission, or cutaneous remission is also there. Then we can use it in weekend therapy or once a month therapy, or maybe once the patient has started showing, like in coming winters, some of the patients, they will start showing reappearance of dryness and plaques and scaling. Then we can give in low dose for a week, and then we can withdraw it. There are so many ways by which we can use cyclosporine in alternative therapy. Now we can combine it with various other therapies, topical agents. We can use with cyclosporine to reduce down its dose. We can use cyclosporine in topical treatment. We can use cyclosporine in reducing doses. We can add on methotrexate in increasing doses once the patient has achieved full remission. We can use cyclosporine with some biologics also. We cannot use cyclosporine with JAK inhibitors. That is very important. We cannot use, methotrexate can be used, but cyclosporine cannot be used. It is already mentioned in various JAK meetings. We have to make sure that we are using cyclosporine so that the cumulative dose in the patient, because patient, we have to always give a buffer of future uses of cyclosporine in the same patient, and we have to mention it in the prescription, and also we have to counsel the patient that whenever the patient goes to any other doctor, should mention that how much cumulative dose of cyclosporine patient has received so far. So now coming on to another disease, which is severe atopic dermatitis. We all know that it is very effective in treatment of severe atopic dermatitis. There are not less than 11, but there are so many studies where cyclosporine has been used. And the best part is cyclosporine in children gives very good results, and it can be used in higher doses because they have rapid renal clearance of cyclosporine as compared to adults. The recommended dose is again 2.5 to 5 milligrams orally, and we can use it for more than 8 weeks. I used it for 6 months in severe cases of atopic dermatitis. But of course, I keep titrating the dose, and we can use initial 5 milligrams if the severity is very high of atopic dermatitis. And this is the do's and don'ts. We have to take down full drug history, and we have to perform physical examination. We have to ask, we have to order all these tests. These are very important during our first visit, and then subsequent visits also. We can, depending upon the history of the patient or depending upon the response of the medicine, we have to use these tests. We order these tests frequently, maybe once a month or 3 months. It has to be done. And also we have to advise patient to go for certain vaccinations. If the patient has not taken any live vaccine, then we should start cyclosporine only after the patient has completed live vaccine. Then after 6 to 8 weeks we can start. And special considerations with children: hepatic and renal impairment. Renal impairment is very important, because if the patient's creatine clearance is compromised, and we should not be using cyclosporine in doses above 2.5. It is very, very much needed then. Otherwise, we should use cyclosporine. We should not use if the renal compromises of a severe grade. On the contrary, patients who are renal transplant patients, who are recipients, they use in them, our other colleagues, they use cyclosporine. They start from 5 milligrams, but they also maintain the creatinine clearance of cyclosporine. And if the patient is varicella zoster virus is there, then on cyclosporine we can give treatment, as well as we can immunize the patient if it is required. And if hepatitis B virus surface antigen is positive, then we have to take help of our gastroenterologist friend. Or if it is core antibody positive, then we should not be using cyclosporine in those patients. Now, these are various American, Canadian, NICE, and European guidelines where different doses were used. In severe recalcitrant psoriasis or in severe plaque type of psoriasis, Americans, they use 2.5 to 5 milligrams in two divided doses, and Europeans, they use 2.5 to 3 milligrams per day in two divided doses. So those adjustments can be done as per our own guideline, our Indian guidelines, or our own understanding about the disease, or about the patient and patient's pocket, because it is not only the cost of the drug, but cost of the investigations, which is very important. And also we know that patients in our setups are not always in a very hygienic environment, so we have to take cue of that. Okay, so there are various studies where comparison was done, and it is said that in this particular study they used it for a very short-term induction therapy for the flares of moderate to severe psoriasis, and then they changed it to some other medication, and oral dosing was between 2.5 and 5 milligrams, which was subdivided into two different doses, morning, evening. This was universally accepted, and the treatment algorithm. This we all know. If there is we need a very rapid drug response, and patient is not comfortable with biologics or IV biologics, then we have to give cyclosporine. That gives the best result. And if some other reason is there, the patient is comfortable, then we can either switch to anti-IL-17 therapy or switch to other oral molecules which are there, like apremilast is there if there is contraindication or the patient is not ready for that. But we should take care of it that with the immunomodulator therapy or immunosuppressive therapies, we should not be pushing the patient for UVA and also not for UVB, because they may theoretically they can lead to skin cancers. Now, newer indications in alopecia areata, there are various studies. It is one of the most common autoimmune disease in humans, and we know that it is a T cell mediated autoimmune disease, and there are initially very few patches, acute patches, then it becomes chronic and which are non-scarring, which then becomes maybe total scalp hair loss. So there are various armamentariums ranging from minoxidil, topical, oral, even tofacitinib, even apremilast, even excimer laser, even corticosteroid injections and topical corticosteroids also. We have to choose our patient, counsel the patient about usage of cyclosporine, because cyclosporine gives to hypertrichosis also in some of the patient, which is not desirable by the patient because it is a non-reversible condition. So, and it can be used as a steroid sparing agent to arrest the disease initially, and then we can switch the patient to some other therapy, whether it is steroid again or non-steroidal. Various immunomodulator therapies are available, so we can use it as a rescue from using a high dose of steroid, initial use of steroid. Or many patients, they Google and they say that, doc, we don't want steroid for hair growth. Or if the patient is a chronic one who has been taking steroids but with little or no response, then we can try cyclosporine in those patients, and some of the patients, they respond very well. And various retrospective studies were done in alopecia areata to evaluate the therapeutic efficacy and safety of oral doses of cyclosporine. And patients, they received treatment for severe atopic alopecia areata in the dose of 2.5 to 6 milligrams in this particular study, cutaneous ocular toxicology in 2014, which is a quite long study. But I don't use more than 3.5 in case of alopecia areata. And in this particular study, there was a significant hair growth observed in almost 45% patients, and 3 patients with alopecia universalis and 2 patients with alopecia totalis. There was no recurrence in 6 months of follow-up, and after cessation of oral cyclosporine treatment. So this is again a good way of reducing down the immune cascade in T cell mediated immunity for this particular disease, alopecia areata. And of course, the patients who were treated with higher dose, they will respond better and quicker than with lower doses. These are some of the pictures from the same study, and oral cyclosporine may be beneficial depending upon our patients, because many of our patients are on polypharmacy, or they have taken some other medication. They are taking sometimes homeopathy also. We do not know what is the interaction between the molecule which we are using and other medicines which they are using, and many times they don't consider that other medicines history is important. So it is our duty to take down the history while prescribing cyclosporine or any other immunomodulator therapy. Now, Stevens-Johnson syndrome and TEN, this is a very effective medication if the Stevens-Johnson syndrome or toxic epidermal necrolysis is around 72 hours to 5 days. If it is beyond that, then whether we use steroid or we use cyclosporine, the results are same. But it is a wonderful steroid sparing agent in Stevens-Johnson and toxic epidermal necrolysis if it is used within 72 hours. Complete disease is taken care of, and the whole of the skin comes back within 5-6 days. This is my go-to drug in within 72 hours of toxic epidermal necrolysis or Stevens-Johnson syndrome in any of the patients, provided their renal functions and their blood chemistry is in line where I can use cyclosporine. And I use in toxic epidermal necrolysis, if the patient is fit, I use 5 milligrams. I start with 5 milligrams per kilogram body weight for at least a week, then I start tapering down. So we know that these are life-threatening emergencies, and mortality rate is high. But so far, my patients where I must have used more than 56 patients. So all of them responded very well to cyclosporine because I started before 72 hours. Here also, it was it was seen that in oral solution, this was given from 3 milligrams divided to 7 days, and then 2 milligrams it was reduced, then 2 divided to another 7 days. And after that, after 15 days, you can stop cyclosporine and taper it down to 0, because then the patient does not require any further drug. There are patients who get toxic epidermal necrosis or Steven Johnson again and again. So we must be sure that we are using the drug in such a way that the cumulative dose is not going to be nephrotoxic. So it was well tolerated by all the patients, and if we compare it with corticosteroid, the result is slightly better. I'll say it is slightly better. So if the patient is fit, or the patient has come within 72 hours, if we use cyclosporine, then we do not use corticosteroid parenteral or oral in patients of toxic epidermal necrosis. That is my personal experience of last 27 years. So this is one of the examples where the patient of Steven-Johnson syndrome, toxic epidermal necrosis, overlap was there and responded very well. Is not my patient. And a meta-analysis also has shown that there is significant reduction of mortality risk with cyclosporine therapy, provided the patient's kidneys are doing fine, patient's blood chemistry is fine, and it was tolerated with very little adverse effect because we are using it for a very, very short duration. And its immunomodulation is very good, and it is a very good treatment option, provided we are started in a very early stage. Okay, now this has been used in some of the studies as oral rinse, and just apply and and use your tongue to move around in the case of oral lichen planus, and shown to improve oral lichen planus significantly. I have not tried because the medicine is very costly, and if the patient does not respond, is costly, or costing almost 4 to 5,000 rupees to the patient. Patients are not very happy with that. So in erosive lichen planus, it was shown in this particular study in IGDVL, it was shown to be giving very good results. At 4 weeks, statistically significant difference was observed in lesions healing between the cyclosporine and placebo groups, and all the studies they have shown very good progressive healing with evidence of reduced erythema and ulceration, and increased reticulation and decreasing pain scores in cyclosporine. Of course, it's a very good immunomodulator, and lichen planus being a cell-mediated, T-cell mediated disorder, it should work very well there also. And so in recalcitrant lesions often require systemic medications, and topical cyclosporine has proven to be an effective alternative therapy in case of oral lichen planus. In severe recalcitrant oral lichen planus, this study has concluded. Now, in pyoderma gangrenosum, I've used only in one patient, and it has given very good result, because I never wanted to use in a patient who was diabetic. So corticosteroid in a diabetic patient. So this has given a very good result. So this can be an alternate to corticosteroids in case of pyoderma gangrenosum, and with wound care has to be given, and it's a very good sparing agent, steroid sparing agent. So again, primary outcome was speed of and time of healing pyoderma gangrenosum. Secondary outcome was specific global treatment response was there, and number of treatment failures were recorded. Resolution of inflammation was seen. There was no report of pain, and quality of life improvement was there with various modalities in almost 120 patients where they have used this particular study, BMJ. They have published in 2015. There is a stopgap randomized controlled trial with prednisolone global treatment response seen by clinician, patient, and independent clinician from digital images, which said that in clinical assessed improvement, cyclosporine was faring better. Vis-a-vis patient assessed improvement, prednisolone was faring better or equal to cyclosporine in various these two arms, where one was clinician and one was patient and one was independent clinical in the form of digital imaging. So, in again, the result of stopgap, by 6 months, ulcers had healed in almost 50% of the patients in cyclosporine group, and comparable to that in prednisolone group. So, if cost is not the factor, and if we are not able to use oral steroid in case of pyoderma gangrenosum, then we can use cyclosporine as an alternative. I have used only in one patient. That's my disclaimer. So they concluded that patients who require systemic treatment, they are likely to respond to cyclosporine or prednisolone equally in the short term. And both of these did not differ across the range of objective and patient-reported outcomes. The treatment decision for individual patient should be guided by in consultation with the patient, or if the patient is having some other polypharmacy where we cannot use either of these medicines, then we have an alternative. That's what the conclusion is. And now it has been used in chronic spontaneous urticaria also. I have not used very frequently because I think that cyclosporine should be reserved for uh, various inflammatory disorders, autoimmune inflammatory disorders, because in case of, if we are using it in urticaria, chronic spontaneous urticaria, we should use it for at least 3 to 4 months, which adds on to the cumulative dosing of cyclosporine if the patient may require later in the life. But in Journal of Allergy Clinical Immunology practice in 2018, close to 900 participants, they used in two different randomized control trials in low dose and in low dose to moderately high dose, 4 to 5 milligrams. They differentiated, and it was seen among patients treated with very low and moderate doses of cyclosporine. 6, 23, and 57% experienced one or more adverse event, and response was seen better in higher dose. So obviously the response is better, and cyclosporine, if we are using for a long duration, if not in such a case of chronic spontaneous urticaria, then we can avoid development of any of the adverse event. So it is effective in low to moderate dose in chronic spontaneous urticaria, and adverse events appear to be dose dependent. And dose of cyclosporine may range from 1 to 5, although I have not used, that is my disclaimer. So in summary, it is a very useful tool, useful medicine to be used in our dermatological disorders, and there is a huge evidence where it can be used in psoriasis, it can be used in psoriatic arthritis, it can be used in other different diseases like lichen planus. It can be used in vitiligo. It can be used in so many diseases where it can be used. Pyoderma gangrenosum and Steven Johnson syndrome. It has shown wonderful results. There are so many guidelines. Different groups have developed different guidelines to be used, but we all should be using cyclosporine judiciously, because the patient does not know what is the medicine, and if they get response, they can order it through the chemist, and they can accumulate the dose, which can be detrimental to their own life. Thank you so very much. We are open for the questions. I'll stop sharing.
Thank you, Dr. Vinay, for a wonderful, exhaustive lecture on cyclosporine.
Thank you, sir.
Covering so many indications of cyclosporine, giving such an exhaustive view on psoriasis, atopic, even pyoderma gangrenosum, alopecia areata, and of course, chronic spontaneous urticaria, which is my favorite topic. Vinay, before I open this for other people for the questions, I have a question to you.
Yeah.
Do you do VZ virus antibody levels in all your patients?
No, I don't know.
So this is only there in the guidelines. So what you do, you tell us that.
I simply ask the patient history of herpes in the family, or herpes in the patient's self, herpes simplex or herpes zoster. And if it is more than 5 years, then I further go ahead. I ask the patient for the investigations, which ranges from complete hemogram, then liver functions, kidney functions, viral markers. Sometimes I go for viral markers if the patient is not very much sure. Then, and lipid profile is very important, and I also go for HbA1c because cyclosporin in pre-diabetics can predispose to diabetes. That is a known fact, and lipid profile can get altered very soon in patients. And if the patient is taking alcohol or some other hepatotoxic food or medicines, then the chances are very bright for the patient to develop some kind of hepatic problem also. Of course, nephrotoxicity is to be measured, monitored, and we should not forget to take blood pressure of the patient, whether the patient is normotensive or the patient says, I don't have a family history, etc., etc. And I always ask the patient, I always tell the patient, see, this is a very wonderful molecule, but you may feel some dizziness, some headache initial 2-3 days. If that persists, go to nearby physician, get your blood pressure checked, and if it is rising continuously, if it is going beyond 140 140 and
90.
100,
Yeah.
100.
In fact, Vinay, this is a very important point you made. In fact, many young patients come to me and I check the BP of every single patient when I want to prescribe cyclosporin. And many young people in their early 30s are also found to have high blood pressure.
Yeah.
So that is where the problem occurs. And then they have to check every week when they're on treatment.
Yes. Twice a week, sir. I ask them to go for twice a week.
So sometimes you may have to reduce the dose.
Yes.
Dr. Ketan, I believe we have some questions in the chat box.
Yeah, we have a few questions, sir. I will just read out. So this is Dr. Soumya. She's telling that, good evening, sir. I am from Bangalore, Dr. B.R. Ambedkar Medical College, first year PG. She's asking, can we use cyclosporine in patients less than 6 years of age? That is children.
Yes, yes, we can use. We can use in children because in children oral solution is available in India, and very good graduated syringe is there where we can use. And in as compared to adults, we can use higher doses also in children because the renal clearance of cyclosporin is better in case of children. Up to 12 years of age, it is better.
Vinay, what is your minimum age for using cyclosporin?
I have used in 2 years and above.
So Dr. Soumya, this is the answer from Dr. Vinay. He has used it from 2 years and above, and he is comfortable using it that way, even though you are right that the guidelines, we won't have the literature below 6 years, but it has been used in atopic. See, atopic dermatitis is primarily a children disease, actually.
Yes.
So it has been used by many of us safely, but then you have to be monitoring it. But as Dr. Vinay said, the children tolerate cyclosporin very well. They metabolize it well. They excrete it very well because of the small size of gut. They excrete it faster. Yeah. Next question, please.
Yeah. Next question is, cyclosporin is used as a crisis buster in psoriasis. So your views, expert views, sir.
Yes, it is a crisis buster. If the patient is having erythrodermic psoriasis, the patient is having psoriasis with psoriatic arthritis or arthralgia is there. If body surface area is large, which is involved, PASI is very high, DLQI is very high, or special areas which are difficult to treat, you can use it. Even in pustular psoriasis, you can use it. I am using cyclosporin, and it is not that cyclosporin, if we use it for say 10 days and we wean it off, it will not have any systemic side effects. We monitor the patient. Continuous monitoring is very, very important. It is not that you just write the patient, okay, fine, you take 200 milligrams a day and go back to home. No, you have to monitor the patient very well. You have to ask the patient for the blood in case of erythroderma and all. Ideally, you should admit the patient because it can become a medical emergency also.
Right. So, Kulkarni ji, what next?
Dusra question is, sir, what dosage are you recommending in chronic urticaria? This.
Sir, ये आप बताइए, मुकेश sir, because I don't use it in urticaria.
So yeah, I use it a lot in urticaria. As the people use in psoriasis, I use in urticaria left and right. When I say left and right, doesn't mean that they are, I don't take precautions. They have to be deserving patients. Any patient who doesn't respond to 4 times the dose of antihistamines is a deserving candidate for cyclosporine. In a young patient who is not hypertensive, who is not having any renal problems, I'll be very comfortable using it. And I normally use 3 milligram per kg body weight in those patients who respond very well to 3 milligram per kg body weight. When I have achieved remission, 1 month after remission, I will reduce the dose to 2 milligram. And then after another month, I'll reduce to 1 milligram. That's one. There are patients who have about 70-80% improvement with 3 milligram, and they are not still comfortable. Those are the patients where I jack up the dose. Otherwise, my standard dose is 3 milligram. The other thing about the cyclosporine usage is normally in one course, I will not go beyond 6 months. I will look for substitutes like methotrexate and all, and I will withdraw it, because if we give for long term, then there is a chance of renal arterial hypertension at a later date. So we don't risk anything in our patient. We do proper monitoring. We do the creat, we do the hemogram. I do it every month, and I tell the patient to check BP every week. And in my clinic, when the patient visits at that time, also we check the BP. It's pretty safe. A lot of patients experience of, a couple of decades. It's my go-to drug. It's a favorite drug of mine. In fact, it works in more than 50% of the patients who have failed omalizumab also. I've seen patients who have failed omalizumab, and it works very well in the omalizumab failures also. But there is a limitation. It works in 80% of patients, which is better than omalizumab that way. But that doesn't mean that it is superior to omalizumab, because omalizumab doesn't require any monitoring. The problem with omalizumab is it is very expensive. The cost is much more higher than cyclosporine. We are comfortable using cyclosporine by experience in psoriasis and atopic dermatitis, in alopecia areata, and so many other conditions. So in chronic spontaneous urticaria, I use it quite a bit.
Thank you so much, sir. There is one question that how do you compare cyclosporine? Basically, I think he's asking topical tacrolimus. Experience cyclosporine versus maybe topical tacrolimus, that he might be asking.
I think the person perhaps wants to ask about lichen planus, oral lichen planus.
Yeah.
Because in oral lichen planus, we use topical tacrolimus also, and oral swishes of. Please answer that.
Yeah, see, we cannot compare it as such, because if I say we cannot compare, because I have not done any comparative study or in a patient, we cannot do left and right side or in the same patient, because lichen planus, oral lichen planus is again a very long course of treatment. So swishes is a good way. Either you use cyclosporine swishes or you use steroid swishes. Any ways by inflammation, we have to reduce it down in the oral mucosa and maintain the integrity of the mucosa. Vis-a-vis, if you say both are different medicines, both can be used, and they give very good, fairly good results. I'll not say that one is superior to another.
Right,
I think that answers the question well.
That answers the question well. So just one question, I think Dr. Mukesh Girdhar already has mentioned. Dr. Vinay Singh, how long do you use cyclosporine?
I have used cyclosporine maximum to 2 years. In an ED patient, I have used it maximum to 2 years with proper documentation and with proper consultation with nephrologist.
Okay.
Patient was in need. Patient could not afford a biologic. This is a patient of recurrent erythrodermic psoriasis.
Right, sir.
To add to this answer, when I said that there is an outside limit, So many patients, if you give cyclosporin for 10 days on and 20 days off, or 15 days on and 15 days off, it keeps working. Because you know
Yes,
what
yes,
happens once it suppresses urticaria, that remains suppressed for the next 10, 15 days time anyway.
absolutely right.
And
Absolutely
then you
correct.
can give it another 15 days go and then take it off for another 15 days. So that way you can use it for much longer period.
Sir, few of my patients are taking for 6 years in the similar manner, once a month therapy, once 15 days therapy, 200 milligrams or 300 milligrams once a month. So they are very happy with continuing psoriasis patients and topicals. So that way we can. I was answering about continuous usage. So
Yeah.
continuously I've used for 2 years, daily basis.
Daily basis. Okay. Okay. So I
But I
think
can vouch for
this.
one thing in atopic dermatitis, especially in atopic dermatitis and urticaria. I mean, you nobody can question the validity of going for cyclosporin very early.
Yes, yes, yes. Absolutely right.
Okay, and just this is for both of you, sir, your experience. In which patient do you choose that, yes, in this patient I have to use cyclosporin?
Vinay, you take first.
That's $1 million question. Sir, आप लीजिए पहले. You answer it first.
Okay. So, as I said in urticaria, when the patient does not respond to 4 times the dose of antihistamine, I don't have too much faith in Montelukast. Sometimes I use it for reasons of the associated disorder like asthma and all, or somebody is having an NSAID induced urticaria. I don't have too much of faith in the H2 blockers also. So I very quickly, prepare myself and my patient also to start cyclosporin and go for the investigations concerning cyclosporin. That is about urticaria. Now, talking of atopic dermatitis, in the atopic dermatitis, if the topical treatment is not good enough and my patient cannot come repeatedly to my clinic for the narrowband UVB light, again, I have to prepare myself, my patient for cyclosporin. If the patient cannot afford, then I have other options, but we know cyclosporin works the quickest. And it's a wonderful molecule to treat atopic dermatitis. Children tolerate it well. We have discussed it. Dr. Vinay mentioned about it in details very nicely. So atopic is the other one. In psoriasis, I use it specifically as a crisis buster. I don't use it long term in psoriasis. I try to find other options. Uh, but as I said, it is the crisis buster. It is the quickest to work. If somebody is getting married or somebody is, uh, having some other interviews coming or some other, personal issues, cyclosporin works very well. Uh, so for me, these are the three main diseases where I use it. I use it in alopecia areata. I've used it in psoriasis also, in vitiligo also. Uh, well, that's all I will say about it. Vinay, your turn.
Sir, for Steven Johnson in toxic pulmonary this is
Yes.
my first drug of choice. I don't use
Yeah, I forgot
corticosteroids.
to mention that's the case with me also. Yes.
And in case of psoriasis, yes, whatever you have covered. Apart from that, the patients who are not responding or who are poorly responding to other conventionals, or once I have used biologics, then I want to, stop biologics because of the pocket of the patient. Then I use it very judiciously and very easily. In atopic dermatitis, again, I will say that if it is moderate to severe atopic dermatitis, I will use psoriasis. I do use cyclosporin as one of my choice because now we are having JAK inhibitors also. They they are also very good. So I use one of the indication I have seen it responding to some extent, not very well, in hidradenitis suppurativa. It acts to some extent. Initially, just to reduce on the inflammation, you can use if the patient has not responded to any of other molecules, and I don't use rifampicin in case of hidradenitis suppurativa because the pus is not, it is a sterile pus, and long-term rifampicin can itself lead to some complications, hepatic complications. So there I use as a crisis buster, initial crisis buster, till the time patient is prepared for other modalities of treatment. Urticaria I have used very less number of cases, so I will not be having much of pyoderma gangrenosum I have used. It is a wonderful molecule in that also. Alopecias I do use in alopecia areata. Children, it response response is wonderful. But only thing in children is that you have to counsel the parents about hypertrichosis. If we are not having any other alternative to be used in children, then only you should use. If the patient's parents are not very happy about hypertrichosis, although it is not found in all of the cases, but once it is there, it is a permanent feature. It does not reduce down. So that's all about my usage.
Okay, so thank you. I think we have covered all the questions now. So, I'd like to give a vote of thanks for both of you. So, on behalf of Emcutics, division of Emcure Pharmaceuticals, thank you very much, Dr. Vinay sir, for your excellent lecture. The lecture was very illuminating, and I also wish to thank Dr. Mukesh Girdhar sir for bringing out the valuable clinical insights. So, I'm sure the audience would take in the insights and the advice of both these senior dermatologists on the panel today. So I wish both of you a very nice evening ahead, and thank you audience for joining us today, and we'll see you soon with some other topic. Thank you very much. Thank you very much.
Thank you, Dr. Kulkarni. Thank you, Mukesh sir.
Thank you, Vinay sir. Thank you, Mukesh sir. Thank you very much.
Thank you.
Bye.
Okay, so we'll end this meeting.